So here we'll start with discussing biochemistry paper 1 MCQs from February 2021. First MCQ is the marker enzyme of lysosome is. So we have a set of marker enzymes for each subcellular organelles. And what is the marker enzyme? Marker enzyme is some enzyme which is specific for that organelle. So when you want to separate that organelle by a centrifugation or a subcellular fractionation, that unique enzyme, with that unique enzyme you find what organelle it is. So that is called as marker enzyme. So for each organelle you have a unique enzyme. For mitochondria it is ATP synthase. For lysosome it is cathepsin. For Golgi complex it is galactosyl transferase. You can remember as Gol and Girl. And for microsome it is glucose 6-phosphatase. Cytoplasm LDH, peroxisome catalase, and plasma membrane it is 5' nucleotidase. So this is the list of marker enzymes which you have to memorize. And if for this question, the marker enzyme of lysosome is cathepsin. So moving to next question, which of the following is a lysosomal disorder? So we have 4 options here. So we'll start decoding from option D. So what is Prions disease? Prion stands for proteinaceous infectious particle. So prion is proteinaceous infectious particle, and that does not have that is not a cell organelle defect. And what is Alport syndrome? So Alport syndrome is a collagen based disorder where collagen 4A5 is the main defective collagen. Also A3 and A4 is affected. And what is cystic fibrosis? Cystic fibrosis is a chloride channel defect. So coming to first option, I cell disease. What is inclusion cell disease? It is an example of protein targeting defect. So what is meant by protein targeting? So for a protein to reach its target organelle, for this to reach a target organelle, you need to stamp this post with some substance. You need to stamp this post with some substance so that that reaches the proper address. Just like you're giving an address on an envelope so that the address reaches the right location. You need to stamp this with a proper address so that it reaches the right cell organelle. So that way, for lysosomal hydroxylases, where should it reach? It should reach the lysosomes. So for this to reach the lysosomes, you need a stamp, and that stamp is called as mannose 6-phosphate. So what is the defect here? Mannose 6-phosphate is not sealed on lysosomal hydroxylases. So the lysosomal hydroxylases do not reach its target organ, lysosomes. So what happens? All these enzymes come out of the cell, but they don't reach the target organ, and they just form some inclusion bodies within the cell, and that is called as I cell. This inclusion bodies, I stands for inclusion. So I cell disease or inclusion cell disease is because of defective targeting of lysosomal hydroxylase with mannose 6-phosphate so that they don't reach the lysosomes. So this is the answer for which of this is a lysosomal disorder. It is inclusion cell disease. So next question is, what is the biochemical basis of using sodium fluoride while collecting sample for glucose estimation? This is the steps of glycolysis. You have one step of glycolysis where 2-phosphoglycerate is converted to phosphoenol pyruvate. I've just put that one step, and that step is catalyzed by the enzyme enolase. So this enolase is inhibited by fluoride. Is inhibited by the enzyme by fluoride. So what happens when you collect the blood sample for estimation of blood glucose? You just draw the blood sample from a patient, you collect it in a tube, you come to the lab, you process it, and you give the result. You give a numerical value. You give a blood sugar value. Sometimes it takes the process. If the processing takes time, what happens? Your blood, which is collected in the tube, can still undergo glycolysis anaerobically. So what will happen? All the sugar, all the glucose units gets broken down by glycolysis, and pyruvate and lactate will be formed. So what happens when you process the same blood sample after 3 to 4 hours? If you don't add any preservative, the glucose content which was present in the blood, that would have undergone glycolysis, and now if you reprocess the same blood sample, the value will be lesser than the normal value. So to inhibit this inherent glycolysis which is taking place inside the tube, you're adding a glycolysis inhibitor which is fluoride. So this fluoride inhibits enolase so that glycolysis is prevented and the blood glucose level estimation is given in the right way. So what is the biochemical basis of using sodium fluoride? It is for inhibiting glycolysis. And next, a 3-month-old child exclusively on breastfeeds presents with incessant crying, poor weight gain. Clinical examination revealed enlarged liver, cataract and positive Benedict's test in urine. The most likely condition is, you have 4 options: von Gierke's, McArdle's, galactosemia and lactose intolerance. So we'll see one by one. Von Gierke's and McArdle's. So before that, what are the positive findings? The baby is exclusively on breastfed, incessant crying, poor weight gain, enlarged liver, cataract and positive Benedict's. So von Gierke's, it is a glycogen storage disorder. What is the problem here? Glucose 6-phosphatase is defective. So the glucose does not reach the cell organelles. So the patient suffers from hypoglycemia. And this glucose gets converted to pyruvate lactate, and that results in lactic acidosis. This glucose the glucose 6-phosphate is used in triacylglycerol synthesis, cholesterol ester synthesis, and that results in hyperlipidemia. And do we get cataract here? No, we don't get cataract here. And what about McArdle's disease? It is again a glycogen storage disorder where muscle phosphorylase is defective here. So M for M, you can understand this way. Muscle phosphorylase is defective here. And what about lactose intolerance? Again, this occurs on exclusively breastfed babies, where the babies get incessant crying and poor weight gain. But we don't see any liver enlargement or cataract. Lactose is also reducing sugar, so that can give positive Benedict's test. But these two are not seen in lactose intolerance. So what is galactosemia? So what is galactosemia? Galactosemia is the defect in the enzyme galactose 1-phosphate uridyl transferase. Galactose 1-phosphate uridyl transferase is the defective enzyme in classical galactosemia. You also have another type of galactosemia, which is galactokinase defect. So what happens here is accumulation of galactose 1-phosphate, which also inhibits galactokinase, and so there is accumulation of galactose. So when there is more accumulation of galactose, you don't have any UDP glucose formation, which is used in conjugation of bilirubin. So the patient also presents with liver enlargement, jaundice, and all these things. So also you don't have glucose for energy, so that also results in hypoglycemia. This occurs in exclusively breastfed infant, so there is enlarged liver, and this accumulated galactose gets converted to dulcitol, and dulcitol is a osmotically active substance. So what happens? That imbibes the water inside the lens of the eye, and that results in cataract formation. And galactose is a reducing sugar, so that results in positive Benedict's test in the urine. So with all the history, the option matching with all the history is galactosemia. So that is the answer here. And which of the following is a derived lipid? So how do you classify lipids? Lipids can be simple lipids, complex lipids, and derived lipids. Simple lipid is just triacylglycerol, where 3 fatty acid groups is attached to a glycerol moiety with ester linkage. And complex lipids is where a simple lipid is complexed with another substance like phosphate, sulfate, like phospholipids, sulfolipids, all these are glycolipids, all these are complex lipids. And what is a derived lipid? When from the simple or complex lipid, you derive with the chemical reaction, you derive some other substance that is called as derived lipids. Examples being fatty acids, steroids, prostaglandins, leukotrienes, dolicol, and terpenes. So these are the list of derived lipids. So from this list, which option you have got? Triacylglycerol is a simple lipid. Plasmalogen is a complex lipid. Ganglioside is again a complex lipid. So prostaglandin is an example of derived lipid. So the next question is major apolipoprotein seen in chylomicrons. So classification of lipoproteins, we have chylomicrons, VLDL, IDL, LDL and HDL. So just directly jump into apolipoprotein column. Here for chylomicrons, the major lipoprotein is ApoB48. Apart from this, you have ApoA, ApoC2 and ApoE. Similarly, for VLDL, the major is ApoB100 followed by ApoC2 and ApoE. Whereas for LDL, it is only ApoB100. And for HDL, it is ApoA1, ApoC and ApoE. So the major lipoprotein seen in chylomicrons is ApoB48. And ApoB48 is an example of RNA editing. It is 48% of ApoB100. It's an example of RNA editing. So next, which of the following enzyme is not a protein? So here all enzymes are always proteins with few exceptions. The exception is ribozyme. What is a ribozyme? Ribozyme is RNA with enzyme activity. So what is ribozyme? It is not a protein. It is RNA with enzyme activity. And examples of ribozymes are 28S RNA. 28S RNA, which is nothing but peptidyl transferase in translation, and snRNA, which is seen in RNA splicing, and ribonuclease P. Ribonuclease P, which is seen in post-transcriptional modification of rRNA. So these are the examples of ribozymes. Ribozyme is an RNA. To which class of enzyme is aldolase classified? So for this you should know the classification of enzymes. You have 6 classification of enzymes which can be abbreviated as OTHLIL. O stands for oxidoreductases, transferases, hydrolases, lyases, isomerases, and ligases. And you have a new 7th class which is translocase. So of these 6 you have a 4th class called lyase, where there is cleaving without addition of water. So example is aldolase. So where do you see aldolase? In which metabolism you see aldolase? In glycolysis and fructose metabolism. So what is the function of aldolase? Aldolase cleaves. So there are 2 subtypes of aldolase. One is aldolase A and aldolase B. In glycolysis, what do you see is aldolase A. What happens in glycolysis? Fructose 1,6-bisphosphate is cleaved to glyceraldehyde 3-phosphate and dihydroxyacetone phosphate by aldolase A. What happens in fructose metabolism? Aldolase B cleaves fructose 1-phosphate to dihydroxyacetone phosphate and glyceraldehyde. So there are 2 aldolases A and B which cleaves the substance without addition of water. Hence it is classified under lyase. Which vitamin is excreted as oxalic acid? So vitamin C is the answer. So vitamin C or ascorbic acid. The major end product of ascorbic acid metabolism is oxalic acid, and that is why increased intake of vitamin C can lead to calcium oxalate stone formation, and it can result in renal calculi. There are vitamins required for the synthesis of catecholamines. So this is the pathway of catecholamines where it is synthesized from tyrosine. So here tyrosine is converted to DOPA by tyrosine hydroxylase, which is the rate limiting step, and DOPA is decarboxylated and forms dopamine. Whenever there is a decarboxylation step, it should contain vitamin B6 as the cofactor. PLP or B6 is required for the synthesis of catecholamines. Which of the following is an uncoupler of oxidative phosphorylation? So for this you should know what is an uncoupler. So first, oxidative phosphorylation is electron transport chain. Here you have 4 complexes, complex 1, 2, 3, 4, where the electrons from the reducing equivalents are transferred between the complexes. And complex 5 is where the proton gradient is converted to ATP. So 1 to 4 complexes where oxidation happens, and in complex 5 phosphorylation happens. This coupling of oxidation and phosphorylation is called as oxidative phosphorylation. Anything which breaks this couple is called as uncoupler. So you have some chemical uncouplers and physiological uncouplers. The chemical uncouplers are 2,4-dinitrophenol, 2,4-dinitrocresol and CCP, whereas physiological uncouplers are thyroxine and thermogenin. So of these, what is answer? It is 2,4-dinitrophenol. What about the other options? Carbon monoxide, cyanide, all these are inhibitors of complexes of electron transport chain. And what is oligomycin? It inhibits FO subunit of ATP synthase complex. Again, it is an inhibitor. So the inhibitors are different from uncouplers. And the same question, which is the physiological uncoupler of these list? Which is the physiological uncoupler? You know the answer, it is thyroxine. Next, it is citric acid cycle is otherwise called amphibolic pathway, amphibolic cycle, because it has both anabolic, catabolic, mitochondrial cytoplasm, reversible, irreversible. It contains proteins and lipid substrates. So what is the answer? First is option B, right? It contains, cycle happens only in mitochondria, it is not in cytoplasm. And it is called amphibolic pathway because it has both anabolic and catabolic pathways, because there is continuous influx of substrates within the TCA cycle, and there is continuous efflux of products also. So as there is continuous influx, you call it as anabolic and catabolic. So in the first image I have shown the influxes. Usually glucose on glycolysis gives pyruvate. With PDH complex it is converted to oxaloacetate. From oxaloacetate TCA cycle starts. So even if it is not via glycolysis, still oxaloacetate can be produced by transaminases from aspartate. And alpha ketoglutarate can be obtained from glutamate. Branched chain amino acids can give propionyl CoA, which can be converted to succinyl CoA. Phenylalanine tyrosine can give rise to fumarate. So this is how continuous influx of substrates happen in TCA cycle. And what about continuous effluxes? This alpha ketoglutarate can be utilized for GABA synthesis. Succinyl CoA can be used for heme and ketolysis, heme synthesis and ketolysis, and malate can be used for gluconeogenesis. Again, by transamination, oxaloacetate can be converted to aspartate. Acetyl CoA can be converted to fatty acids. So this way there is constant efflux also. So this is called as amphibolic pathway because it is both anabolic and catabolic. The total number of ATPs generated in one cycle of TCA cycle. So for this you should know in one cycle how many NADH or reducing equivalents are produced and how many ATPs are produced. See, in this cycle we have one NADH here, one here and one here. So there are 3 NADH. One NADH gives 2.5 ATPs. So 3 NADH can give 7.5 ATPs. And how many FADH2? There is only one FADH2. So one FADH2 gives rise to 1.5 ATPs when it goes through electron transport chain. And there is one substrate level phosphorylation where a GTP is produced. So here I add 1 ATP. So in total 7.5 plus 1.5 plus 1, it is 10 ATPs in total. So the total number of ATPs generated in one TCA cycle is 10. Which of the following causes negative nitrogen balance? So nitrogen balance is something which is maintained by protein intake. When the intake is more than excretion, you have a positive nitrogen balance. When it is vice versa, when you excrete more protein than the intake, that leads to a negative nitrogen balance. So this table shows you the factors which maintain positive nitrogen balance and negative nitrogen balance. So the positive nitrogen balance is maintained when you have a sustained growth hormone, insulin and androgen, which are all anabolic. Which is insulin is anabolic, and pregnancy and convalescence, that is any recovery from acute illness, that all causes positive nitrogen balance. Whereas negative nitrogen balance is caused by hormonally, it is caused by cortisol, and any acute or chronic illness, just like immediate post-op or trauma or burns, or any chronic illnesses like malignancies and uncontrolled diabetes, all these lead to negative nitrogen balance. And of course protein deficiency leads to negative nitrogen balance. So of the following options here, they are asking only the hormone. They have given you the hormonal factors. So of these, which causes negative nitrogen balance is corticosteroids. Next is factors affecting BMR are all except. So these are the factors which affect the basal metabolic rate: age, sex, temperature, exercise, thyroid hormone and fever. How each affects: age, with increasing age you have increasing BMR. As the age increases, BMR increases, but in old age the BMR is reduced. What about sex? Male have high BMR. Male sex has high basal metabolic rate. And what about temperature? When the temperature is cold, the basal metabolic rate is, your body tends to have a higher metabolic rate at cold temperatures because of thermoregulation. And what about exercise? When you exercise more, there is increased cardiac output. So more exercise leads to more cardiac output, and that leads to increased heat production. This increased heat production causes increased basal metabolic rate. And thyroid hormone, for the same reason, thyroid hormones increase the heat production, and that is why hyperthyroidism, there is increased BMR. And same way fever, there is increased heat production that causes high BMR. So the factors affecting basal metabolic rate are all except glucagon. Which of the following amino acid is required for the synthesis of heme? So the first step of heme synthesis is condensation of succinyl-CoA with glycine. So which amino acid is required for heme synthesis at the first step? It is glycine. Sickle cell anemia is characterized by the following except. So basically, what is sickle cell anemia? Sickle cell anemia is an example of point mutation where at 6th position a non-polar glutamate residue is replaced by a polar valine residue. Sorry, it is polar glutamate residue which is replaced by a non-polar valine residue. So at the 6th position, this is the point mutation taking place. And what is option D given here? Option D says valine in 6th position of beta chain is replaced by glutamate. It is not this, it is the other way. In the 6th position of beta chain, glutamate is replaced by valine. So what about the other options? Homozygous recessive inheritance, yes. And it causes chronic hemolytic anemia. Yes, sickle cell anemia causes chronic hemolytic anemia. And because of that, that leads to sickle crisis where there is increased episodes of pain, and that is because of hemolytic anemia you have hemolytic jaundice that results in hyperbilirubinemia. And there is polymerization of deoxyhemoglobin. Because of sickling, the deoxyhemoglobins get polymerized, and this happens at an exaggerated rate in hypoxic conditions. So what is the answer here? Valine in 6th position of beta chain is replaced by glutamate. Factors affecting the fluidity of cell membrane are all except. So these are the 4 factors which affect the fluidity of cell membrane: cholesterol content, length of hydrocarbon chain, degree of unsaturation, and nature of polar head group. And this cholesterol content is indirectly affected by transition temperature also. So when the temperature is below the transition temperature, the content is directly related to the fluidity. Cholesterol content is directly related to the fluidity. And when the temperature is above transition temperature, the cholesterol content is inversely related to the fluidity of cell membrane. And it is also affected by length of hydrocarbon chain and degree of unsaturation. When there is more unsaturated fatty acids, the fluidity is also higher. Polyunsaturated fatty acids leads to higher fluidity of cell membrane. So which is not affecting, tight junction is not affecting the fluidity of cell membrane. And impaired function of aquaporin leads to. So you should know what is aquaporin. Aquaporin is a water channel and it is mediated by arginine vasopressin hormone. So how aquaporin functions? When there is binding of arginine vasopressin hormone to its receptor, so that translocates the aquaporin which is within the cell to cell membrane, to collecting duct. So when it reaches the collecting duct, it starts reabsorbing the water, and this water is again brought inside by other aquaporin. Aquaporin 2 is present at the collecting duct which reabsorbs the water. So impaired function of aquaporin leads to nephrogenic diabetes insipidus.